Hello, and welcome to Prescribing Hope for Atopic Dermatitis. My name is Raj Chovatiya. I'm an associate professor at the Rosalind Franklin University of Medicine and Science Chicago Medical School and founding director of the Center for Medical Dermatology and Immunology Research in Chicago. Today, I'm joined by Dr. Linda Stein Gold. Want to introduce yourself, Linda?
Absolutely. Hi, I'm Linda Stein Gold. I'm the director of Dermatology Clinical Research at Henry Ford Health System in Detroit, Michigan.
So today, we're talking all about steroids, and in particular, phobia around steroids, fear around steroids, appropriate use for steroids. You know, dermatology's been built on the back of steroids, and I think that this is a really important conversation to have today, knowing that we have a lot of newer options. How do you handle this discussion when you're talking to your patients about appropriate and inappropriate fears around steroid use?
Yeah, and this is a really important conversation. It's important because our patients learn a lot online. So they come in with some preconceived ideas of what's good medicine and what's not. In my mind, I think steroids still have an important role, but they're a short-term solution to a long-term problem. So I think they're appropriate in the short term, especially getting a disease under control, but they're not a long-term solution. So I usually tell them, use the right way on the right body surface areas, they can be very, very effective.
Yeah, I couldn't agree more. The way that I talk to my patients is I say, look, we're gonna try something, and what I want you to do is let me know when you come back in a few weeks how often you were using this topical corticosteroid, how helpful it was, were there times where you were able to get clear, and that can really help build a use case for, okay, this is a medication they're gonna use once in a while appropriately. This might be fine. But if they come back and saying, Doc, I had to use this every day, twice a day, for every week that you gave it to me to even have some semblance of control, it's not the right treatment option. And I think that that's where we have a lot of great topical and systemic options that have come our way to take the place of topical corticosteroids. Now, I want to ask you about sort of some of the specific concerns patients cite about topical corticosteroids. We know that there's a lot of media information about how topical corticosteroids can cause new problems that you didn't have. Topical corticosteroids can make you get addicted to them, and it's really hard to break that cycle. How do you handle some of these tough conversations with your patients, especially knowing that you have a lot of good medications in your back pocket?
Yeah, I explained to them that there's a time and a place for topical steroids, and we have to use the right ones in the right places. But we also have a lot of other options, as you mentioned, and I think the non-steroidal topicals of today are a completely new generation of medications.
That's right. And when we think about non-steroidals, patients may have tried some of those before, things like tacrolimus, pimecrolimus, and we know that they've not necessarily delivered on the hope that we had. But in today's day and age, with medications like topical ruxolitinib, roflumilast, tapinarof, I feel like we're able to give our patients a lot more of what they'd expect from a topical corticosteroid in a non-steroidal package. And so maybe the last point I'll add, just thinking even beyond topical corticosteroids, how do you sort of address this question around systemic corticosteroid use too, knowing that a lot of your patients have actually experienced systemic steroids and benefits of that as a treatment option too?
And I think that a lot of patients, they know if they go to an emergency room with a flare-up of their skin disease, the emergency room doctor is going to give them potentially a short burst of corticosteroids, or maybe they're going to get a shot of a corticosteroid. And we've really come to understand that that's not the best way to practice medicine in treating our atopic patients. And we both know that the guidelines have actually recommended against that because we have other options now to more holistically get these patients under control.
So going from safety concerns about one class of medication to another, we talked about topical corticosteroids, but one of our newest available types of medications are topical Janus kinase inhibitors, and in particular, topical ruxolitinib, both for the treatment of atopic dermatitis and vitiligo. There's also a lot of complicated information out there about Janus kinase inhibitor safety information, especially when you're looking at social media. So how do you handle that conversation in terms of helping your patients feel appropriately equipped to use a medication like that?
I explain to my patients that when we look at the package insert for our topical medications, they often mirror what we see for the systemic medications. And when we use a medication topically, we don't get the type of systemic absorption where we would have systemic manifestations. So I take a few minutes to explain where the box warning came from. And I also take a few minutes to explain the topical ruxolitinib has been studied even down to age 2, and we were involved in those clinical trials. And this is a medication that is highly effective. And JAK inhibitors, we both know, there's almost nothing better for getting an itch under control. And the fact that we can use that topically to minimize the itch or even negate the itch is really very exciting for our patients. The fact that we can take one medication and use it on the face, on the eyelids, on the broken skin, on the hands, anywhere on the body, as long as we keep it and stay in our lane and keep it 20% or less, we can simplify the treatment regimen. We can use it acute, we can use it non-continuously on a more chronic basis, and I think this really sets our patients up for success.
I couldn't agree more. And when we think about some of the concerns with topical corticosteroids, especially our high potency agents, we think about atrophy, systemic absorption, even adrenal axis suppression. Those are actual real side effects. And in the case of a medication like topical ruxolitinib, I would agree with you completely that it's important to counsel around a boxed warning, but it's also important to think about what was actually seen in the course of the studies. And when you sort of put that alongside efficacy, alongside tolerability, it really does shift the scales in terms of making it a very easy to talk about treatment approach. And I think that usually defrays any safety concerns our patients have.
I agree.
So if we want to give it the too long didn't read version, topical corticosteroids still have a time and place in dermatology. Appropriate use case scenarios are really built on their properties in acute settings, but for chronic disease, we really have a lot better options that can give our patients improvement of their signs, symptoms, and quality of life. Thanks so much, Linda.
Thank you.